My name is Simon Carley and I'm a Professor of Emergency Medicine here in Manchester, speaking this week at the Royal College of Emergency Medicine conference on two topics. And the first topic I'm talking about is around second victims. And this is a concept I got interested in after looking after a number of colleagues and a number of training doctors who have been involved in serious incidents. And I'm sure if you're an emergency physician, you'll be familiar with those set of words, do you remember that patient you saw? And it strikes fear and just stops your heart when it happens. Because in the sort of medicine that we practice, where risk is inevitable, where we are probabilistic decision makers, things don't always go well. Now, some of that is just inevitable. Patients don't have a great outcome because they're unlucky. But we see so many patients and we see so many stressful environments that occasionally we do make mistakes. And many emergency physicians would be familiar with a terrible error, either that they've made themselves or that they've seen somebody else do. And things can go wrong. You might misread an ECG and a patient may come back having had a myocardial infarction or even die. Now, we're caring professionals, and when that happens, the impact is enormous on people. The processes within trusts and within the organisation, the GMC, are about learning from mistakes, and we have high-level investigations and serious untoward incident processes, and they're great. But the problem is that they don't necessarily recognise the impact on the person. Now, back in 2000, a chap called Wu identified this concept of a second victim, in that although the patient's damaged, although the relatives are obviously very upset about what goes on, we don't spend enough time thinking about the effect on the doctor, or the nurse, or any other form of clinician involved. Because if you're a caring professional, and we are, it's devastating when these things happen. So second victim syndrome is when people don't recover from such an event. Some people are very resilient and they're able to go through an event and learn from it, become very passionate about patient safety afterwards, change their practice and share it. But many others don't. Many others go through almost a grief reaction, or certainly a change reaction, where they go through a period of chaos, trying to restore their personal integrity, trying to make sense of why they, who perceive themselves as good doctors, and they often are, have made such a terrible error. The natural reaction to such an event is to feel ashamed, to feel embarrassed, to feel that you're not a good doctor anymore. And of course, that's not true. How do we get people through this? Well, the outcome for this can be awful. Some people thrive. Some people are really good after this and they become champions of patient safety. But the majority go on to what I would describe, or what's described in the literature, as survivors. So they're irrevocably damaged by the event. They may have had an event with a child and therefore stop practicing seeing children or avoid certain types of patients. And I think we've all seen that in people we've worked with. And at the other end, many people actually leave in some way, shape or form. They may leave the type of practice, so they may avoid seeing certain patient groups like trauma. They may avoid the hospital, so they feel embarrassed in the locality where they are, so they may go move and work somewhere else. Some people leave emergency medicine. I think that is a problem for our junior trainees. And in, thankfully, a small number of cases, but great tragedy, some people leave emergency medicine entirely, choose an easier specialty, and I even know of people who've left medicine entirely. That's a huge loss to our profession. It's a huge loss to our patients. We need to help these people get through and rehabilitate them. It's tricky. People will have these events. We can't avoid them. And there's some great work about stress, about how the mental state that you have when the stress is applied affects your response to it, this concept of resilience. And I know it's all trendy at the moment. There's lots of different ideas about how we can build resilience, but all of the ideas, mindfulness, meditation, 3 great things, exercise, sport, they all have similar themes. They're all about taking time out of life, time out of work, to stop, reflect, rebalance, and to look at the positives in life, not just focus on the bad things. I'll give you an example. If you have a bad event during a day and 20 great events, what do you think about when you go to sleep at night? It's not the great things, but we need to retrain our minds to do so. And in the talk here and on the blog post, we're going to talk about ways that you can do that, really simple ways that you can do for yourself and for your colleagues. It takes me back to the problem. If you or one of your colleagues has been involved in a terrible error, if you are still or they are struggling with it, what can we do to support them? We can build our departments to be compassionate. We can build our colleagues to think about these things and talk about the emotional impact of cases that we see. It's really important. But fundamentally, we have to recognise that this can happen, and when it does, the most important thing you can do to yourself, to your colleagues, to your organisation, is to listen, to understand, and to be kind.